Hello everyone. In this presentation, I'm going to cover the topic of staging and grading of periodontitis. Periodontitis is an inflammation of the periodontal tissue resulting in clinical attachment loss, alveolar bone loss, and periodontal pocketing. When the presence of interdental clinical attachment loss in the oral examination has been identified, then the patient is a suspected case of periodontitis. Now, we need to ascertain whether this clinical attachment loss is caused by local factors only, such as endoperio lesions, vertical root fractures, caries, restorations, or impacted third molars. And if not, we need to ascertain that the interdental clinical attachment loss is present in more than one non-adjacent tooth. In this case, we have a periodontitis patient, and we need to make a comprehensive periodontal diagnosis through periodontal charting and full mouth radiographs. If the periodontal charting does not show any probing pocket depth of more than 4 millimeters, like 4 millimeters or more, then we need to evaluate the full mouth bleeding on probing. When the bleeding on probing is higher than 10%, the diagnosis will be gingival inflammation in a periodontitis patient. When it is lower than 10%, then the diagnosis is a patient with reduced but healthy periodontium. If the periodontal charting shows probing pocket depth of 4 millimeters or more, then the diagnosis is a periodontitis case, and that will need assessment and staging and grading, as we will see. So in order to establish the stage of an individual case of periodontitis, the following information is needed. We need a set of full mouth x-rays, a full periodontal chart, and periodontal history of tooth loss. So we ask the patient about the reasons behind losing any teeth. Was it like caries or trauma or periodontal disease? And that is what we care about in the context of this staging and grading is tooth loss due to periodontal disease. Then we define the stage of the disease by assessing the severity. So we use information such as the clinical attachment loss, the bone loss, and history of periodontal tooth loss. And we also get the complexity, and this is complexity of management, by assessing the probing pocket depth. We know the deeper the pockets, the more complex the management. Furcation also makes it that much more difficult to manage. And presence of intrabony lesions. Also tooth hypermobility, secondary occlusal trauma, bite collapse, drifting, or having fewer than 10 opposing teeth. All these are complexity factors that we should consider. And after the stage has been determined, extent is added as a secondary descriptor and reflects the percentage of teeth in the dentition that are affected by the attachment or bone loss at the level of severity that is defined in the stage. And this is according to Sands et al. 2020. So for example, in a particular case that has been diagnosed to exhibit stage 3 periodontitis, the extent will be determined to be localized if the percentage of teeth with bone loss beyond the coronal third of the root is less than 30%. On the other hand, if a larger proportion of teeth is affected by bone loss of that severity, the extent will be considered as generalized. Okay, so just to repeat again this point, that the extent is not the extent of all the teeth affected by clinical attachment loss or bone loss, but the teeth in that particular stage. Say if it's stage 3, so how many teeth are affected by stage 3, and if it's 30% or less, then this is considered localized stage 3, and if it's 30% or more, then it's generalized stage 3. So this slide shows the framework for staging and grading of periodontitis. The staging refers to the severity in terms of initial, and that would be stage 1, moderate, that would be stage 2, severe, that would be stage 3 and 4, and stage 4 is severe advanced periodontitis with extensive tooth loss and potential for loss of the whole dentition. And again, as we said, complexity of management plays a role in staging, as we will see in the next few slides. And grading refers to the risk of progression the anticipated treatment response, and the potential impact on systemic health of the patient. So first thing we are going to talk about is assessment of the stage. So we have 4 stages, and the first thing to do is to start with a high-level assessment of the patient periodontal status. The high-level assessment uses a narrow set of parameters to make the first distinction of whether the periodontitis case is either stage 1 or 2 versus stage 3 or 4. And that's a good starting point for more detailed assessment later on. So if the clinical attachment loss is greater than 5 millimeter, or if the bone loss affects the middle 1/3 of the root or beyond in more than 2 adjacent teeth, then the diagnosis is either stage 3 or 4. If the clinical attachment loss is 5 millimeters or less in fewer than 2 teeth, we should still look for furcation lesions, degree 2 and 3, and if these are present, then the diagnosis is still either 3 or 4. And if absent, again we would check for the probing pocket depth. And if there are greater than 5 millimeter and more than 2 adjacent teeth, then the diagnosis is either stage 3 or 4. And finally, if the probing pocket depth are between 3 and 5 millimeters, then the last thing we will look for is the history of periodontal tooth loss. And if there was any history of periodontal tooth loss, so the patient said I had a tooth that wiggled and the dentist removed it, then the diagnosis is either stage 3 or 4. If all of these parameters that we discussed were absent, then the diagnosis is either stage 1 or 2. Regarding the pocket depth, the clinical judgment should be applied to use this criterion to upgrade from stage 1 and 2 to stage 3. So for example, the presence of pseudo pockets, the periodontitis case should stay as stage 2. Why we would have pseudo pockets? We have a lot of inflammation and the gingiva has swollen a little bit. So we know that after oral hygiene instructions and after the initial treatment, the gingiva will shrink, right? This slide shows the high-level assessment of the patient periodontal status, and there is a question that's frequently raised, and that is how to reliably differentiate between bone loss up to 15%, that's initial periodontitis or stage 1, of the root length versus bone extending between 15 and 33% of the root length. So clearly, the point here is not to scrutinize the level of bone loss with the level of precision extending to single percentage point, but instead, the intent is to distinguish between an anticipated stage of periodontitis that has barely resulted in alveolar bone loss from a more substantial bone loss that extends within the coronal third of the root length. So when we see a clear bone loss or proximal bone loss within the coronal third of the root, in most situations, this will be stage 2 rather than stage 1 disease. So stage 1 disease is usually characterized by incipient attachment loss in the presence of early radiographic evidence of disruption in the alveolar bone support, such as breaks in the integrity of lamina dura, and rather than actually increase in the distance between the CEJ and the crest of bone, which is about 2 millimeters in health. Now, it must be realized that either stage 3 or stage 4 disease may reflect severe or very severe periodontitis. However, the primary distinction between the two requires that an experienced clinician ask the following 2 central questions that essentially represents a distillation of the case treatment. So these questions are: number 1, does the patient extent and severity of periodontitis pose a threat for the survival of individual teeth, or rather the survival of the entire dentition? So if it's a threat for the entire dentition, this case belongs to stage 4 rather than stage 3. And the second question is, does the total therapy envisioned to address the sequelae of periodontitis in the particular patient involve extensive multidisciplinary oral rehabilitation? So if due to periodontitis where we have already history of periodontal tooth loss and we are losing some other teeth, and the bite has collapsed and some teeth has drifted and there is mobility grade 2 and greater, and we are calling a team with a periodontist, orthodontist, uh, prostodontist. In this case, because it's very complex in management, this belongs to stage 4. So if the assessment is that the current level of periodontitis threatens the entire dentition and consequently treatment requires extensive oral rehabilitation involving collaboration of multiple experts, and this is beyond the need of occasional extraction and limited prosthetic reconstruction, then the appropriate stage for the patient is 4 rather than 3. And it's important to note that this assessment involves a collective assessment of potential complexity factors rather than mere checking of a box approach to isolated features. So you can just like find one tooth that is grade 2 mobility and automatically say this is complexity factor of stage 4, and we will put this patient in stage 4, right? So you need some clinical judgment. So these two questions that we discussed are the main questions you should ask yourself before assigning the patient to stage 4. And as we will see later on, that for the guidelines of treatment of periodontitis, we have guidelines for stage 1 to 3, and then separate guidelines for stage 4 because it is that much more complex in management. So we have some rules for staging. Number one, the stage is patient based and not a tooth based concept. And therefore, we assign one stage to the patient. So the worst site will determine the stage, and that will be the stage for that particular patient. And again, the stage can shift upward over time. So patient was stage 3, he didn't show up for follow-ups for a few years. Then he had more attachment loss. Now it's more than 5 millimeters or radiographic bone loss extending to mid third of the root or beyond. We will put him in stage 3. But the initially assigned stage is retained even after improvement post-therapy. So he came as stage 3. We reached the end point of treatments, no pockets more than 4 millimeters, no low bleeding score and all this good stuff. Still the patient's stage 3, right? And the complexity factors that determine the stage must be evaluated collectively, not in isolation, to arrive at a clinically meaningful assessment. So uh, let's look at and try to summarize what we've discussed regarding staging. So, stage 1 and 2, we have clinical attachment loss less than. Um, so, in stage 1 and 2, we have clinical attachment loss less than 5 millimeters and bone loss in the not more than coronal one third of the tooth. And very important, no tooth loss due to periodontitis, right? Stage 3 and 4, we have attachment loss of 5 millimeters or more, or bone loss extending to mid third of the root and beyond. And we have history of periodontal tooth loss, right? Now, to separate between stage 1 and 2, we would say if we can see bone loss extending in the coronal third in the X-ray, it is probably stage 2. And the maximum probing depth is 5 or less if we see like initial like loss of the integrity of the lamina dura over the crest of the bone, or just the in like very slight attachment loss like 1 to 2 millimeters and the probing depth is less than 4, that is stage 1. And here, what is neat about this classification, if when I identify patient as stage 1 or stage 2, and I know that all the pockets are 5 millimeters or less, and the bone loss is mostly horizontal, I know that I can manage this patient in my office without referring him to a periodontist through oral hygiene instructions and non-surgical treatment and so on. Okay, to differentiate between stage 3 and 4, so again, the history of tooth loss, if it's 4 teeth or less, that's stage 3. If we have 5 teeth or more, that's automatically stage 4. And we said that we have, if we have like in stage 3 and 4, both have probing pocket depth more than 6 millimeters or more, vertical bone loss of 3 millimeters or more, furcation involvement class 2 or 3, and moderate ridge defects for that's only for stage 3. Stage 4, the headline is it threats the entire dentition and it needs complex interdisciplinary management. So in addition to these features in stage 3, we have more need for more complex rehabilitation, masticatory dysfunction, mobility grade 2, severe ridge defects, bite collapse, drifting, flaring, and less than 10 opposing pairs. And after assigning the stage, we describe the extent as localized if less than 30% of the teeth are involved with that stage, or generalized if more than 30% of teeth are involved in this stage, and molar incisor pattern, that's a very specific pattern. Before, in the old classification, we had a separate entity, localized aggressive periodontitis. So this will replace this. So in that case, it will be either what was known as aggressive periodontitis. It comes in young age. So it will be probably stage 3 or 4, and it will be molar incisor pattern. Now we'll move on to assessment of grade. So grading aims to indicate the rate of periodontitis progression and the response to standard therapy and the potential impact on systemic health. Grading is based on three fundamental principles. One, not all individuals are equally susceptible to periodontitis. And two, that periodontitis progression and severity is a function of multifactorial influence on a patient's response to the microbial challenge. And three, some periodontitis cases require more intensive control of the microbial biofilm and inflammation than achieves using current principles of care. So when we are grading, assigning a grade to a patient, we start with the assumption that all patients are grade B, which is a moderate rate of progression, and then we will look for evidence, and according to this evidence, the patient would stay in grade B, or we can shift him to grade C, which is rapid rate of progression, or grade A, which is slow rate of progression. So what do we mean by progression? Is the progressive disease over time, and in that case, if we have no previous records over the past 5 years, we would use the percentage of bone loss per age, and we could also use the case phenotype. And we will discuss in this slide, we can see how to do the percentage of bone loss per age. So we estimate the radiographic bone loss at the site that appears to have the most severe destruction, like here on this molar A, right? And then we determine whether the bone loss is likely to be in the most coronal third, the middle third, or the most apical third of the root. That will help also in staging. So we can see here the bone extends well into the middle third of the root, and here on the premolar it extends into the coronal third of the root. And then we divide the radiographic bone loss percentage by the patient age, right? So if we have, for instance, 30% bone loss and the patient is 50, so 30 by 50 is 0.6. If we have 40% bone loss and the patient is 50, so 40 by 50 is 0.8. If we have 60% and the patient is 50, so 60 by 50 is 1.2. So back to the slide for grading. So the progression, as we said, if we have no previous records, we would use the percentage of bone loss per age or the case phenotype. So case phenotype means if we have here in grade B that we will assign most patients to before moving on, and according to evidence we can move the patient, is that the destruction is proportionate to the amount of biofilm deposits that we can see. If we have heavy biofilm deposits with low level of destruction, that would be slow rate of progression grade E. And if we have that the destruction exceeds the expectation given the biofilm, that's grade C, and that would probably be generalized or molar incisor pattern. As for the bone loss percentage, so from 0.25 to 1, all this is grade B, moderate rate of progression, which we will expect in most patients. Slow progression is less than 0.25, and rapid progression is more than 1. Now, if we have previous records over the 5 years, then we can simply look at the radiographic bone loss or clinical attachment level. And if it's less than 2 millimeters over the 5 years period, then it's B or moderate progression. Grade A will be uh, no evidence of clinical attachment loss or bone loss over the past 5 years. And grade C would be more than 2 millimeters or more over the past 5 years. Now, grade modifiers are diabetes and smoking, and diabetes or smoking are two of the most well documented risk factors for periodontitis. So, as we can see, if the patient smokes less than 10 cigarettes per day or have diabetes but it's well controlled, meaning his glycated hemoglobin A test is less than 7, then the patient again falls into grade B. However, if the patient smokes 10 cigarettes or more, or he's uncontrolled, so his glycated hemoglobin test is 7 or more, then he falls into grade C, meaning I can see a patient with percentage of bone loss per age that lies between 0.25 to 1, but because he is smoking 10 cigarettes or more per day, I will upgrade his stage or shift it to grade C. Or if the patient is diabetic and he's not controlled, then we'll shift him to grade C. Now, what we mean by impact on systemic health, uh, for that I would say, although there is a substantial evidence associating periodontitis with other diseases such as cardiovascular disease, type 2 diabetes, and adverse pregnancy outcomes, the evidence that treatment of periodontitis will result in predictable benefits with respect to any of these systemic conditions is rather limited. So the systemic inflammatory burden of periodontitis is well documented, at least as measured by high sensitivity C-reactive protein. Okay, and given that well-established role of elevated high sensitivity C-reactive protein in cardiovascular disease and other chronic conditions, the impact of effective treatment of periodontitis on the C-reactive protein levels may be an important parameter to monitor in certain patients with stage 3 and 4. But to be honest, clinically, we wouldn't do this part, risk of systemic impact. It's good to know, but clinically, what we need to look for is either we have records, so we look for the clinical attachment loss or radiographic bone loss over the past 5 years, or we don't have records for the past 5 years, so we use the percentage of bone loss per age, and then we use the grade modifiers, which is smoking and diabetes, to assign a grade. And again, as for the biomarkers, so we would say that current evidence indicate that certain combinations of salivary biomarkers may add value in the assessment of periodontal therapy. However, we need additional evidence and clinical utility for this to be like mainstream and used in the clinic. So again, for clinical purposes, we're using these clinical data and the grade modifiers, and that's it. So, how to write the diagnosis after we made sure that the patient is a periodontitis case and we did staging and grading? So, we would write the stage followed by the grade followed by the extension. Remember, we said the extension is the extension of the teeth affected by this particular stage, not all teeth affected by bone loss or attachment loss. So, for example, we would say periodontitis, stage 3, grade C, generalized. Means that 30% or more of teeth are affected by stage 3 periodontitis. Or we could say periodontitis, stage 2, grade B, localized. So in that case, less than 30% of teeth are affected by stage 2 periodontitis. There are, however, some gray zones while we are staging and grading. So let's look at this example. The severity of periodontitis in a 50-year-old patient based on radiographic bone loss at the site of the most advanced destruction is compatible with stage 2 disease. For example, the bone loss extends within the coronal third of the root. So thus the presence of one or a few 6 mm pockets necessarily upshifts the diagnosis to stage 3. So remember, in the complexity factors we said 6 mm pockets or more will shift the stage to stage 3. So the answer to this is it's not necessary. If the severity of bone loss does not extend beyond the coronal third of the root length, and the presence of a couple of 6 mm pockets does not actually automatically entails the need for more complex treatment. So upstaging, because of complexity factors, requires a meaningful, integrated appraisal of these factors, again by an experienced clinicians, and the correct implementation of the staging system does not lend itself to automated algorithms based on check boxes or presence or absence of isolated features. So you don't see like one 6 mm pocket. Oh, then this is complexity. It belongs to stage 3 and 4, right? Another example: a male 65-year-old patient has experienced no tooth loss, is radiographically intact, and has no interproximal pocketing with a depth of 3 mm or more. The level of the gingival margin approximately is at most sites coronal to the CEJ, except for few surfaces located at non-adjacent teeth where the gingival margin is located at the CEJ. A loss of attachment of 2 mm is recorded at these few sites. Does this patient have periodontitis? So at first glance, yes, more than two non-adjacent sites have 2 mm of uh, clinical attachment loss, so this patient should have periodontitis. But then again, look at the age, 65, no history of periodontal tooth loss. So that's a borderline case. So according to the above description, the probe tip apparently, yes, it penetrates within the junction epithelium to a level apical to the CEJ in a few interproximal sites with shallow probing depth. We have no visible recession and no radiographic evidence of alveolar bone loss. And since this is middle-aged patient appear to be periodontally intact, a diagnosis of periodontitis is not justified, right? However, if the same phenotype, the same case here, was in a much younger patient, so in his 30s, 40s, this may signify a true incipient periodontitis. So again, as we can see, clinical judgment is paramount at arriving in correct diagnosis after assessing the totality of the patient data. So the steps for staging and grading: again, step one is initial case overview. Once we say this is a suspected case of periodontitis, we'll do full mouth radiographs, full mouth charting, and we will ask about the history of periodontal tooth loss, right? And then we will establish whether this patient belongs to stage 1 or 2 or stage 3 and 4, right? And then we will differentiate furthermore between stage 1 and 2 and stage 3 and 4. And then we will establish the grade. So it's either we would have records for the past 5 years where we can look at just the difference in clinical attachment loss and radiographic bone loss, or we would just use, if we don't have the records for the past 5 years, the radiographic percentage of radiographic bone loss divided by the age of the patient at the worst site. And we would apply the grade modifiers, the systemic risk factors, diabetes, and smoking if encountered. So the final point I want to make is, what is the value of the 2018 classification? What is new? What is the value of this classification? So number one, it assesses the current level of severity of periodontitis and its impact on the treatment required. And number two, it determines whether a periodontitis patient is highly likely or less likely to respond predictably to standard principles of treating periodontitis. And finally, The new classification would guide a clinician to recognize factors that indicate the patient's disease trajectory if it's more complex, and then it should be managed accordingly, so according to your level of experience, or you can refer it out for treatment. I hope this presentation helped you in understanding more about the staging and grading, and if you have any questions, please email me your questions, and thank you.